in that project, and actually for both of the projects, we determined that a patient was rural if they had a rural-urban commuting area code of 10, which is the most rural of the RUCA codes. And these codes are developed by the U.S. Department of Agriculture, and they look at population density, they look at urbanization, they look at commuting codes or patterns. And so we really want to look at this very, very rural population. And so what we learned from the LVO project was that we kind of had to be creative about how we looked and characterize this patient population. Not because, just mostly because we had to figure out how to find a signal for a lot of patients, given that there were not a lot of rural patients in general. So what we looked specifically at were patients who were transferred in to a hospital. So these would be hospitals that were participating in Get With the Guidelines, who receive patients for thrombectomy. There's really not a good way to connect patients who are transferred. So we wanted to make sure we were looking basically at the same patient and not duplicating patients who maybe were in a Get With the Guidelines hospital before transfer. So we looked into the same things, the social determinants of health, demographics. We looked into our primary hypothesis was that patients who reside in rural areas would undergo less thrombectomy after transfer. So again, even in this patient population, the rural patients comprise about 3% of the population of interest. Patients who were transferred in for thrombectomy, for those patients, non-rural patients comprise about 5% of the patients. In looking at the social determinants of health, we found similar patterns as to with the LVO project, where patients who resided in rural areas, again, were less likely to have a bachelor's degree, had lower median income, had less home ownership. So it was not probably surprising, considering that was something we found with the patients who had LVO, but we wanted to look at the whole registry. And then when we look specifically at the patients who were transferred in, we found the same patterns. We also found that patients who resided in non-rural areas underwent mechanical thrombectomy more than patients who resided in rural areas, which was our hypothesis that that it wasn't entirely surprising given, all of the obstacles to transferring a patient for thrombectomy. But what we did find is even when we controlled for social determinants of health, including education level, income, home ownership, that disparity still persisted. So we can't say it's entirely from those specific social determinants of health. And it was interesting to us because there is some literature on patients with large vessel occlusion who reside in rural areas, and a lot of the disparities are sort of attributed to these social determinants of health. We also found that the patients had similar stroke risk factors, whether they were rural or non-rural, and that's something that has been assumed in the past, that some of these disparities are because patients who reside in rural areas have poorer vascular risk factors. So it's just kind of interesting to see all of that. So that's kind of our main conclusion from that project. So.